Welcome to EHJ Today from an annual ESC meeting in London 2015. My name is Erik Holy from the University Heart Center Zurich, and I'm very proud to welcome Professor Frans van der Werf, one of the giants in cardiology and former editor-in-chief of the European Heart Journal and currently emeritus professor of cardiology at the University of Leuven. Welcome, Frans.
Thank you.
Frans, over the last decades, you have very closely followed and also actively contributed to the evolution of cardiology as a subspecialty in internal medicine towards an almost independent discipline with its own subspecialties. Of all the innovations which you have witnessed, which achievement has been probably the most striking, into your opinion?
Well, of course, everyone will give a biased answer to this. So, you know, I have been working mostly in the field of coronary artery disease, and this is indeed still an important part of cardiology. And looking back at what I have witnessed, how an acute myocardial infarction was treated when I was a fellow, and how it is now, I think, and this is reperfusion therapy essentially, so getting the artery open. For me, this was a major achievement. I'm not saying that this is the greatest achievement in cardiology, but looking at the numbers of lives saved, looking at the high mortality in the CCU, before the CCU, I think this has changed the treatment of acute cardiac care.
Frans, all these achievements wouldn't have been possible without the dedication of excellent clinicians that also had and were very enthusiastic scientists. So what would be today your advice to young fellows at the beginning of their career who would like to follow in your footsteps?
Well, I think as a young cardiologist, you have to take at a certain time a decision. Am I willing to work in a non-university hospital later on, or am I willing to work in a university hospital with all the consequences, financially also, a lower salary or a salary and not an income per fee? That's, I think, a decision you have to take. When I was young, it was easier because at that time all the community hospitals, the non-university hospitals couldn't do anything of interest. The cath lab was more or less reserved for the university hospital. This has changed. Now also the tertiary care hospitals, besides university hospitals, are able to do nice things, to do interventional cardiology, think about ablation also. So, and they can also participate in clinical trials, in the big clinical trials. So this has changed, and I've seen that the last years in my hospital. So excellent people, also interested in research, said, well, why should I stay in a university hospital? Because I can do more or less the same and get a higher income. But I'm sure at the end, and certainly when you are becoming older, all the work that is being done in a non-university hospital is getting routine. Even if it is an intervention, it becomes routine. And I think the new exciting things are still being developed in a university, in an academic atmosphere. Yeah.
Frans, we mentioned an important point that nowadays things have really changed, and basically, I mean, the amount of data we have now is huge. We have the need for basically a very intense clinical training at our early stage of the career, and on the other hand, the methods in research become more and more sophisticated. So, Frans, do you believe that it's still possible to achieve a competitive level being a good clinical scientist and a researcher?
I think it is, but you cannot be a good clinician and an expert in electrophysiology and in, let's say, stent or OCT, to name a few. So I think you have to narrow your interest into one specific aspect of the research, let's say electrophysiology, and then being a good clinician as a clinical electrophysiology. Same if you want to be an invasive cardiologist and you are interested in OCT and doing research in that, of course, you cannot be an electrophysiologist. It's more of a problem if you are really interested in basic research. Think about cell therapy and doing really basic work. Then it becomes very difficult to become, to remain a good clinician, because so much work has to be done in the lab. So choices have to be made, and I think it's more difficult now because it's all much more complex than 20 years ago to be really a competitive researcher and at the same time a good clinician.
Frans, you have contributed to the excellent reputation of European cardiovascular care, not only through your groundbreaking research, but also through activity within the ESC. How important is that at the early stage of the career for our young fellows to get involved actively within the ESC? And at which stage of the career would you suggest would be the best moment?
I think it's extremely important to become a fellow of the ESC for many reasons, and even more now than 20 years ago, because of, well, we are living in one community, and so a lot of the exchange of ideas, meeting people from other countries is so important, and this meeting is an excellent example. Even I went to the poster sessions. If you see all the people there from different countries discussing these things, I think it's important. For me personally, it was also important for my career, because at a certain time, I was already 4 years in the board, somebody asked me, would you be interested to be the editor of the European Heart Journal? And I said, yes. And that, of course, has also helped my career. My name became more important as an editor than before. And so this was, yeah, a bit by coincidence, but anyhow, in general, being a member of the ESC, coming to the meetings, the smaller meetings, is very important.
Finally, Frans, my last question. Maybe you remember 2 years ago, you gave at the ESC meeting in Amsterdam a very exciting lecture about the probably 10 most promising therapies in the near future in the field of cardiology. Following this exciting lecture, you gave an interview and you were asked which of these promising therapies would probably be the most promising. And you mentioned at that time cell-based therapies. What is your answer today?
First of all, I have to say that a lot has already been achieved in cardiology. If you look at cardiovascular mortality, life expectancy, which is linked to that, it all has improved dramatically over the last 20 years. So what we can gain now is only small pieces of a better quality of life, perhaps of a slightly longer life expectancy. I think still that cell therapy has the promise, but really the most important studies have not yet been performed. And just to mention one, which is supported by the European Union, the BAMI study, supposed to randomize patients with after an MI with a poor LV function versus cell therapy and versus placebo or control. It's difficult to get the patients in because there are so many studies with other cell types, and so I am still waiting for really a major breakthrough for confirming what I said 2 years ago, that this is the most promising therapy. You can say, well, lowering further the cholesterol levels, yes, that might be important. But we have to wait what the clinical results are on top of statins, which are already there. So all the major breakthroughs, or so-called major breakthroughs, are the gain is small, and that's because we have been so successful in the past.
It is indeed a very, very exciting and challenging field, and we're waiting for further results. Frans, thank you very much for sharing your visions, opinions, and experience with us here on EHJ Today.
It was my pleasure. Thank you.